Welcome to ICU Primary Prep Quest. This is our another primary snippet. Last time we discussed about respiratory changes in newborn, and today we are going to talk about cardiovascular changes at birth. So Mike, welcome again, and can you please walk us through those changes?
Thanks, Swapnil. So I have to start with an apology. I brought up breastfeeding the last time. I think we might be able to get away without it this time. But we talked about the baby changing colour from deep purple to pink and how that took enormous respiratory effort and respiratory changes. Now, that's all very well and good, but unless it's matched by an increase in pulmonary blood flow, the baby will stay purple. And that's probably what I do every day of my life as I work in a paediatric intensive care unit looking after blue babies with heart problems. Their major problem is that they don't have adequate pulmonary blood flow because they don't have the normal transition. So the baby's taken its enormous big breath almost instantaneously with that because of the stimuli that's caused it, largely the cold air, the bright lights, the noise, the fact that some midwife is smacking them on the bum to get them to breathe. Those changes also cause a massive increase in sympathetic activity and start to cause the changes that occur to the circulation. So the very first thing you notice is that the babies are very blue. Their saturation in utero, as we know, is 60 to 65%, and that's because they've got fetal hemoglobin with a P50 of about 19, and they have about 18 grams per decilitre, so their oxygen content's pretty close to 15 mils per decilitre, just for some numbers for your MCQs. And then what happens to the umbilical cord with all of those stimuli is that it starts to contract. So there's smooth muscle in the vessels of the umbilicus, and that parallels the separation of the placenta off the wall of the uterus. So as the baby comes out, they start breathing, and the ECMO circuit starts to disengage from the placenta and stop working. But prior to that, to stop the baby bleeding to death, you get contraction of the arterioles and the venous system within the umbilical cord. So that causes a couple of things to happen. Obviously, number one, they've now lost their placental ECMO circuit, so they can't oxygenate through the placenta. The second thing that happens is that they get a reduction in venous return to the right heart, so their right atrial pressure falls. But they also get a massive increase in systemic vascular resistance because of the loss of that very low pressure AV shunt that they had as their placental circuit. So now the left atrial pressure goes up. So now you've got an increase in left atrial pressure and you've got a decrease of right atrial pressure. So the patent foramen ovale flap valve drifts across from the left-hand side onto the wall of the atrium and functionally closes. So now they've lost one of their intracardiac shunts. Now, that's not a fixed closure, and it can certainly pop back open, which we can talk about later. But effectively, within the first couple of breaths, that doorway has closed, and the right atrium and the left atrium are now separate. With that closure and with the changes that are occurring, the baby's taken a huge, deep, big breath and augmented the volume of the lungs. You've now got a massive reduction in pulmonary vascular resistance because the lungs are now open and you've recruited all of those collapsed vessels. So the pulmonary blood flow increases towards normal cardiac output, which we would expect. And that enables the baby now to go from purple to pink. Okay, so you can actually watch that happening in real time as a baby takes a few breaths and starts to change colour. So the cardiac output at birth is about 300 mils per kilo per minute. It's almost double or triple what an adult, and that will now drop down to about 150 mils per kilo per minute over the first 6 weeks. But initially, the cardiac output is enormous. The right ventricle, which has been doing all of the work up until now, is the same size or a little bit bigger than the left ventricle, and that has some implications for looking at the ECG because you'll normally see right ventricular hypertrophy and a right axis deviation in a brand new baby. But the left ventricular mass over the next 6 months will massively increase as it starts to pump blood around a growing baby's body with an increased systemic blood pressure. So you'll get left ventricular hypertrophy, and that dominance of the right ventricle will gradually disappear and melt away. And the pulmonary vascular resistance similarly will almost disappear over the first 4 to 6 months of life. So you've effectively now got an adult circulation. Now, babies have a heart that's obviously smaller, so their stroke volume is smaller, but they also have less myocardial active contracting cells versus connective tissue within their heart. So over time, they have to hypertrophy those cells and grow a few more. The other thing is, as we've talked about before, is they have an inadequately developed sarcolemma. So the T-tubule system is almost non-existent at birth. And that's why babies are very, very sensitive to extracellular calcium concentration. So in an adult, if I give you a bolus of calcium, you'll know that you'll get hypertensive. If I give a bolus or an infusion of calcium to a newborn, they'll get that vasopressor effect, but they'll also get an inotropic effect. So calcium's an inotrope in the newborn period. And that goes as long as it takes for the sarcolemma to develop towards a normal adult system. So their heart rates to begin with to maintain their cardiac output are pretty high. So a normal baby would be anywhere from 120 to 160. usually drops down to 100 to 120 by 6 months, and then down to about 100 by 6 years. That would be roughly normal, just to have some numbers in your head. And similarly, the systemic blood pressure is much lower in a newborn, and the ranges vary, but you're looking at anywhere from 60 to 90 for a normal systolic blood pressure. And again, that will rise to about 100 by about 6 years of age. So those are two numbers to remember, 100 and 100 by 6 years for both your heart rate and your blood pressure, just to have some ballpark figures if you're ever going to walk into a room and look at a sick child. So we've mentioned about the fetal hemoglobin. As part of the changing rheology of the baby, that hemoglobin has to get converted from fetal hemoglobin to adult hemoglobin. So there's about 80% of the baby's hemoglobin is fetal hemoglobin at birth. It's already started to convert over to adult hemoglobin before it comes out of the in utero environment. And that drops to about 5% by 6 months and then 1% in adults. So if you have a look at the blood gas machine in your unit, you'll often see some abnormal hemoglobin species in adults, and it may be up to 1% of the hemoglobin in a normal adult can still be fetal hemoglobin. So that blood obviously has to get turned over, so it hemolyzes and gets consumed, and the liver glucuronidates all that bilirubin. Now, those enzymes are a little bit underdone at birth, so they take time to increase in power. So for the first few days of life, the baby goes from being bright pink to a sort of an orangey yellow colour. And that's a function of the conversion of that fetal hemoglobin over to adult hemoglobin and the bilirubin load that has to be dealt with. So that's pretty much it for the cardiovascular changes. And I would recommend that you have a look at the Physiology of the Newborn, Chapter 74 in the latest edition of CAM. It's got a very nice graph of all of the different pressure elements that occur in the first few breaths and then over the first few weeks of life. And it's good to have that sort of graph in your head. You would never be asked to reproduce that graph in the exam, but it just gives you a sense of the rate of change of the various cardiovascular parameters. But it also, I think, identifies the enormous changes that have to occur within those first few minutes of life, and it's really quite striking. The other thing to remember is that babies stay desaturated for some time. People talk about babies returning to fetal circulation. Well, that's impossible because they don't have a placenta. What they can do is have complications of transition, and they usually have ongoing pulmonary hypertension, which can lead to right to left shunting. So the problem of pink babies becoming purple overnight is because of pulmonary hypertension and right to left shunting, usually through the ductus arteriosus that should have closed, but it's not due to a return to fetal circulation because no one's gone and dug up the placenta and reattached it. So it's just important to remember why things are happening. But babies stay blue for the first at least 10 minutes of life. And if you look hard enough at their actual measured saturation and compare it to arterial saturation, they're often sitting in the mid to low 80s for several hours after birth, and that gradually goes to the 90s and then 100 over the first day or so. So it's one of my bugbears is that you almost certainly can't get 10 out of 10 for your APGAR, even if you're a type A medical student, unless you're breathing supplemental oxygen, because your hands will be cyanosed, and it is not normal to be 100% saturated as a newborn baby. So anyone who tells you that's happening, tell them they're a liar or they're giving supplemental oxygen.
That's right. Another interesting thing that I recently realized is about the nervous system, which is interesting, is that they have a very sympathetic dominance, which kind of changes to parasympathetic dominance in adulthood at some stage after 1 year or 2 years of life. But that's why when newborns, they're breathing at a rate of around 50 to 60 breaths per minute. And also their heart rate is around 150, which is completely normal. But the same heart rate or same respiratory rate for adult will be considered as super abnormal. And that's why looking at those rates, if you're doing the adult intensive care training, you shouldn't be freaking out because babies are meant to do that. Obviously, with adult, that's completely abnormal. But that's because of predominantly development of the vagus nerve and myelination that occurs over the period of time rather than at birth.
Yeah, that's a very important point, Talk. I mean, I had a few little notes on the metabolic changes. So you're quite right. The body surface area of a small baby at 3 kilos is about 2.5 times what an adult is for an equivalent weight. So you've effectively got at basal metabolic rate, because you're 2.5 times the surface area, you're going to need almost twice as much oxygen consumption to maintain your temperature. So the oxygen consumption of a newborn is 6 to 8 mils per kilo per minute. It drops to about 5 to 6 mils per kilo by the end of the first year. And then you're an adult, you're consuming about 3 to 4 mils per kilo per minute. So you can see the implications for thermoregulation, because babies, sometimes they come out fairly chubby, but they don't have a lot of subcutaneous fat most of the time, unless they're the baby of a diabetic mother. but they rely on their brown fat, which is, as you've mentioned, it's got some sympathetic dominance in there with beta-3 mediated activity to cause non-shivering thermogenesis, because abnormal muscles in baby don't shiver very well. So babies aren't very good at shivering and aren't very good at sweating. They will sweat if you heat them up enough, particularly if they're term, but preterm babies won't. They haven't developed sweat glands. But their chief mechanism for maintaining heat is brown fat consumption. They're not very good at getting out of the heat, so they can overheat if you wrap them up or warm them too much. But that raises the concept of the thermoneutral environment, which anaesthetists love because they undress people and paralyse them. But intensivists need to be aware of it too, because we've often got some naked patients with wet clothing that have come into the unit for whatever reason, drowning or something. And obviously newborn babies that have been born and brought to your unit to be resuscitated, God forbid. But the thermoneutral environmental temperature is the range of environmental temperature within which the body will maintain its temperature with minimal oxygen consumption. So by definition, if you become too hot or too cold, you've suddenly got to consume more oxygen to enable you to make heat or lose heat. So for a full termer on day one, your thermoneutral range is pretty tight. It's 32 to 34 degrees. If you're under 32 degrees, those babies start to get stressed and have to use their metabolic fuel and their brown fat to generate heat. So that's what we call that is the critical temperature. It's not the critical temperature in terms of physics and liquefaction or of gas, but it's the temperature at which a baby starts to use its metabolic stores to maintain heat as opposed to maintain body blood sugar. But that's a good point, Swapnil. Yeah, the changes in the nervous system. I mean, I think there's changes that occur in the liver, there's changes that occur in the renal system, changes occur in the nervous system. They're sort of peripheral parts of the syllabus, and you'd be pretty unlikely to get asked them in an exam. I think that the examiners are much more expecting of you to understand the physiology of the respiratory and the cardiovascular changes. And perhaps a little bit on how babies stay warm, because those are the sorts of things you might be asked to maintain in a unit. If you've got a pregnant woman who delivers in the unit, you'll see it all happening. Or if you're in a peripheral centre and you might be called down to help resuscitate a small baby in the emergency department, because they might expect the baby to go to intensive care whilst you're waiting for a transport team if your hospital doesn't have a neonatal unit. So being a little bit aware of trying to keep babies warm and trying to keep sugar up to them and accepting lower saturations or understanding why they might have suddenly gone blue in the middle of the night. Those are all things that it doesn't hurt to know. And, the transition is just an extraordinary physiological event. I mean, talk about separation from ECMO as being something we look at in adults and think is a big step. Well, imagine having to do that when you're 3.3 kilos and you don't speak English. It's pretty impressive.
It is. Thanks, Mike. Couldn't have had a better speaker than you for this topic, especially the someone who works every day in that environment. So thanks again for explaining in a very simple language. So that's the end of our today's episode. We'll be back in sometime soon with another episode of Primary Snippets. Till then, goodbye and have a nice time.
See you later, everybody.